Welcome everyone to the first seminar of the new year. So not of the academic year, but of the new year. I hope you all had a very nice break. We're very happy to have today Professor Kathleen Hammond of the Lincoln Alexander School of Law of Toronto Metropolitan University. She will be speaking about structural racism and income-related health inequities in the Ontario government and its public health unit's response to the COVID-19 pandemic. Professor Hammond is an assistant professor at the Lincoln Alexander School of Law. Prior to joining Lincoln Law, she was a postdoctoral fellow with the research group on health and law at McGill University's Faculty of Law and a visiting fellow with the Petrie Flom Center for Health Law and Policy at Harvard Law School. She holds a JD and a BCL from McGill, completed an master's in philosophy and multidisciplinary gender studies and a PhD in legal sociology at the University of Cambridge, where she was a Gates Cambridge Scholar and a Commonwealth Scholar. Her research spans across health law, policy, technology law, gender, families. She specializes in assisted human reproduction and is conducting two SSHRC-funded studies in this area. Recently, she has been working also on COVID-19, looking at accountability and liability in the context of COVID-19 responses, which is the topic of her presentation today. So without further ado, so you'll speak for half an hour, 40 minutes, and we'll open it up for questions, first with the students and then the audience in general, and maybe even online, but I'm not sure if I can capture the I'll check on my computer if I can see it, because there's people online also.
Great.
Okay, very good.
Hi, everybody. Thank you so much to Professor Lemon for inviting me in. So I'm going to be talking about a project that I did today as part of a grant that I had been working at with profs at McGill University, where we were looking at government accountability and liability in the context of COVID. And when I moved from McGill to the Lincoln Alexander School of Law, I picked up this project with two of my RAs who were my co-authors on the paper, Katie Chung and Nosha Nula, who both had backgrounds in public health. And we were looking at this right kind of in the context of when the pandemic was happening and working with the kind of limited amounts of materials that were available at that time. So I'm going to start by talking about structural racism and income-related health inequities and the way that we defined them for the purposes of looking at this paper. And then going to just very briefly give you a sense of what the emergency powers were that the Ontario government had at its disposal during the pandemic. I'm going to talk a little bit about the methods that we used in order to evaluate the impact of the Ontario government and its public health unit's response. And then I'm going to talk a little bit about our findings, which roughly fall into kind of two main parts. For those of you who read the paper, you might have thought, why didn't they just put it into two separate papers? And I have to say, I wondered that myself when we were kind of in the thick of how long it ended up being. But fundamentally, the first part of the paper looks at four aspects of the Ontario government's response and asks questions about the extent to which structural racism and income were taken into account in structuring the way that those responses occurred. We also then look at best practices in other jurisdictions to ask questions about what other measures the Ontario government and its public health units could have taken. In that second part of the paper, we then answer the question of whether the Ontario government had a moral or legal obligation to combat the health inequities that we identify in the first part of the paper. And then we finish by providing some general recommendations going forward, because as we know, public health units and other research bodies operating in health and the sciences have identified that the COVID-19 pandemic is perhaps an indicator of bigger and more large-scale pandemics to come in future. And so part of our thinking with this paper was to have mechanisms that we could think about putting in place as the pandemic kind of unfolded, but also to think towards the future. What went wrong in the way we responded here and how to move forward. So for the purposes of this paper, I want to draw the difference between what we meant by health inequality and what health inequity means. So when we talk about health inequality, we are focusing, for instance, in differences in health achievements of different groups that don't have a moral element attached to them. So for instance, younger people generally tend to have better health than older people. This is an inequality. When we talk about health inequity, however, and when we used health inequity for the context of this paper, what we were focusing on is the inequalities that stem from injustice and that are linked to social determinants of health. So here we were focusing on the fact that social determinants of health influence health, and many are not within the control of people, and they stem from systemic biases. So an inequality can also be inequitable. We also were focusing specifically on structural racism, and here we define structural racism as the culmination of ways that society fosters racial discrimination by reinforcing systemic inequities, segregating groups, and preventing their equal participation in education, political, and health system. And for our use of low income, here we were focusing on the income level at which a family is in what is called a straitened circumstance, because it has to spend a greater portion of its income on necessities than the average family of the same size. And so here we were focusing on existing definitions and understandings of income that are defined by governmental authorities. You'll notice as well that the way that we look at structural racism and the way that we look at income are intertwined, and that is because of their inextricable interconnection. And you'll notice also at the beginning of the paper, we talk about how the intersection of multiple variables are going to and have throughout COVID led to different and worse health outcomes. And particularly, we decided to focus on these two because they had been pinpointed and have traditionally been identified as two inextricable factors that tend to lead to worse health outcomes. So in the context of doing this research, and in order to kind of situate the work that we were doing, we first started by looking at the history of health in Canada and the way that particular marginalized groups have been impacted. So for instance, we looked at the impact on marginalized groups during prior pandemics. So we looked at, for instance, influenza, and we looked at SARS. We also looked at the reoccurring patterns that we see in access to healthcare among marginalized groups that currently exist. So for instance, there is actually not a huge amount of literature in Canada. There's much more, for instance, in the US that actually identifies the barriers that are faced by particular groups in access to healthcare. But we looked in Canada, for instance, at barriers that are faced by Indigenous folks. We looked at difficulties in accessing specialist services, and we also looked at impact in accessing privatized services. So for instance, mental health care or dentistry. In the context of the COVID-19 pandemic, there began to be, in the later stages of the pandemic, data that emerged that started to indicate what the impact was on particular groups. It had been predicted by Dr. Theresa Tam that it would impact marginalized groups in a disproportionate way. And this has a lot to do with the fact that disasters generally highlight long-standing health inequities for members of marginalized groups. And data, for instance, from 2021 showed that racialized populations made up about 69% of Toronto's COVID-19 cases, and that 39% of those cases were from lower income households. So before I kind of get into the crux of evaluating exactly what that response was from the Ontario government and its public health units, I wanted to start by giving you a bit of a sense of what powers the Ontario government had at its disposal in the context of the COVID-19 pandemic. So the first thing to note is that the bulk of pandemic response ultimately came from the provinces and not the federal government. That being said, the federal government did also have powers at its disposal, for instance, the Emergencies Act, that ultimately ended up being used in the context of the Freedom Convoy. It has the POG power. It also adopted a number of pieces of legislation, for instance, dealing with pecuniary and financial matters. But if we focus just in on the provinces, and as you know, we used Ontario as our main kind of point of study for the purposes of this piece. In addition to typical policy and lawmaking powers that the Ontario government has, they also have particular powers that can be used in the context of an emergency. So for instance, they have the Health Protection and Promotion Act, and they also have the Emergency Management and Civil Protection Act. So the HPPA, for instance, is general public health legislation that has special emergency powers. It allows the Chief Medical Officer of Health to issue particular directives to health boards or to medical officers if an emergency sets in with health impacts in Ontario. There's also, as I mentioned, the Emergency Management of Civil Protection Act, or the MCPA, and this is Ontario's general emergency legislation. It allows the Lieutenant Governor and Council to declare a state of emergency and to make a wide range of orders to prevent, reduce, or mitigate harm. So if you look at my slide at the front, you can see a number of examples of things that come from these two particular acts, where powers are able to be used in order to make actions that might not otherwise be able to occur. So for instance, data collection, the fixing of prices, distributing and making available necessary goods, et cetera, et cetera. So these are additional powers that are at that disposal in the context of the pandemic. Okay. So what we ultimately ended up doing in this paper is we decided to focus on 4 aspects of the Ontario government and its 34 public health units response. So I did just want to emphasize that the Ontario government operates and administers healthcare by virtue of its 34 public health units, which actionalize many of the policies that are put in place by the Ontario government. And so we focus both on specifics from the Ontario government, but we also focus in on the actions of these public health units as well. And we decided ultimately to focus on data collection on COVID-19 and health inequities. The second thing that we decided to focus on was the administration of COVID-19 testing. The third thing was the provision of medical services to individuals with COVID-19. And the last one was the distribution of COVID-19 vaccines. So these were the 4 aspects of the response that we focused on. And as I mentioned, we ended up focusing in and highlighting central areas under each of these 4 aspects of the response where structural racism and income-related health inequities were apparent. So this appears in part 2 of the paper. We also looked at steps that could have been taken based on best practices that we were seeing in other jurisdictions, whether that was other provinces or other countries. That part also appears in part 2 of the paper. And then that third part of the paper answers the question, now that we have identified these concerns, is there a moral and legal duty to address them? Okay, so let's talk about this first part where we identified structural racism and inequities in relation to income that existed in those 4 aspects of the Ontario government's response. So the first one that we looked at was data collection on COVID-19 and health inequities. Data collection on COVID-19 had an interesting and kind of long history that unfolded in the context of the pandemic. Ultimately, we ended up with incomplete data collection and no accounting for equity-related indicators, which is the type of data that we needed in order to be able to identify vulnerable populations and to take protective and preventive actions early on. Ultimately, we have kind of this series of situations where the Ontario government initially refused to collect this type of data. Then we had a number of private bodies. So for instance, the Black Health Equity Working Group was formed and they put pressure on the Ontario government. to collect this data, and they in fact started collecting this data themselves at tracing centers. Eventually, we see a situation where the Ontario government decides that it's not going to collect it at testing centers, but it is going to collect it in the context of tracing centers. But we also saw how effectively this kind of data, if it had been collected early, could have been used. So for instance, in the Peel region, just west of Toronto, they collected this type of data quite early on. The data revealed that the South Asian community had been disproportionately affected, and they were able to kind of put in place initiatives of their own in order to kind of encourage testing and later encourage vaccinations among that community. So the collection of that data helped to be able to identify recurrences and problematic issues for particular groups early on in order to be able to put in particular measures to help with that. So the second one was the administration of COVID-19 testing. And we identified a number of issues that came up here that had particular impacts for marginalized groups. So the first one was that testing was not initially available to people in congregate settings. So for instance, right off the bat, it wasn't available, for instance, in group homes, it wasn't available in supportive housing, it wasn't available in shelters, correctional facilities, retirement homes, long-term care homes, etc. Many of these congregate settings ended up being the types of settings where we saw disproportionately large numbers of cases of COVID later on. And so if, for instance, that testing had been available earlier and we had been able to identify the numbers and the way that they were increasing, that perhaps could have stopped the spread, and procedures could have been put in place, for instance, in order to not have people in such close quarters during that time. The second was barriers to accessing test sites and to acquiring the rapid antigen tests. So test sites in particular ended up having a lot of issues. For instance, if you tried to go during COVID, you probably discovered that there were a lot of wait times, there was a lot of backlogs. In many cases, they were put in areas that were difficult to access by virtue of public transport. In terms of the rapid antigen tests, the way that they ended up being distributed was by virtue, for instance, of small company or large, I should say, companies like, for instance, Shoppers Drug Mart, and they ultimately got to make some of the calls about how they would distribute them to people, on what grounds they would distribute them, and many of the locations of the particular retailers that were distributing them were not available in particular neighborhoods, for instance. So this again made it quite difficult to get access to these tests. The third one was this lack of paid sick leave. So it wasn't until April 2021 that Ontario actually amended the Employment Standards Act in order to require 3 days of leave for reasons related to COVID-19. If we think of how long those symptoms last, and if we think of how long somebody, for instance, is contagious, we know that that is an insufficient amount of time to provide to somebody. And this is particularly important given that folks who are in the types of jobs that do not allow as much flexibility and do not allow, for instance, as much sick leave might be those who need access to this in the biggest way. The last one was lack of available housing to isolate. Because given that you do a COVID-19 test and you do get access to that and you find out that you were in fact positive, in a number of situations, there was very little that some people could do in order to actually put themselves in a position where they were not potentially going to pass on COVID-19 to other people. And so this was an issue as well. There was insufficient housing and space to isolate. And eventually housing was put in place in Ontario, but for a variety of different reasons, it only seemed to largely operate at about 40%. And so again, there are these structural and procedural questions here of why weren't, for instance, people told about the ability to be able to isolate in this available and funded housing the moment that they got their test rather than after they waited to receive their results. The third one had to do with provision of medical services to individuals with COVID-19. So again, here we dealt with a number of particular aspects that had particular impacts for certain groups. So for instance, the first one was a lack of OHIP coverage. Eventually, Ontario decided to cover the costs of medically necessary services for uninsured patients. And they also eventually waived the wait time to get access to COVID for new immigrants. But there was a continued demand for documentation at certain facilities. So here, obviously, what we were seeing was an informational translation problem where some facilities were still asking for that OHIP documentation, even if it wasn't actually required. And so this made people hesitant to actually seek out those medical services. The second one was, of course, that a lot of health providers moved towards using, for instance, telehealth services. Telehealth services is not entirely covered in all situations under OHIP. Some people don't have access to, for instance, stable internet connections to be able to do this. Libraries were closed during this time, and so it meant that some groups were unable to access these services. A third one has to do with mask distribution. So again, I'm sure many of you noticed during the context of the pandemic, not only was there a small amount of masks available in certain times, the prices increased exponentially on particular types of masks, like N95 masks. So one thing that we saw in other jurisdictions was that governments, for instance, provided masks to people, and or they actually fixed prices for masks so that they weren't available to some groups while being unavailable to others who couldn't afford the cost of an N95 mask. And then the last one is has to do with insufficient measures that address social determinants of health. So when we think about medical services and we think about COVID-19 and disparities in health generally and their connection to the social determinants of health, underlying measures such as, for instance, a basic income program can be the kinds of things that can alleviate and or improve those social determinants of health such that we lead to a general lack of disparity in health overall. So again, there are these kind of larger implications from the COVID-19 pandemic that give us indicators of changes that could be made irrespective of the pandemic that would help to reduce these health inequities. Okay, last one that I wanted to mention is the distribution of COVID-19 vaccines. So as many of you may remember, there was a 3-phase rollout program that was used. In the first phase, it prioritized high-risk populations, for instance, like those living in congregate settings, healthcare workers, Indigenous population, people over the age of 88. In the second phase, there was a focus on folks who were living in shelters, group homes, who had certain health conditions, who were caregivers, and also those who lived in what were called hotspot communities. And then the third phase was kind of this more general phase that included everyone who had not been included in those prior 2 phases. So if we think about the way that those phases were constructed, and if we think about, for instance, that second phase where there was this focus on these hotspot communities, in many ways, what those hotspot communities were trying to do is they were trying to target people who were overrepresented in the number of COVID-19 cases. However, when we look at the numbers of people who were disproportionately affected by COVID-19, Black and South Asian folks, for instance, were among the most overrepresented in those numbers. And in some ways, they were meant to be targeted by those priority groups. But instead, because they took this place-based approach, in some ways, it means that some people who do not live in those particular areas were overlooked. And actually, there have been since some criticisms about how those hotspot areas were actually determined. And some of those hotspot areas have been critiqued for not actually encompassing folks who made up those disproportionately affected numbers of people. The second had to do with barriers to delivering vaccines. So one of the things that we saw is what were called vaccine deserts. So specific neighborhoods of the city actually didn't have many locations in which you could get a vaccine. We saw, for instance, some mobile and pop-up clinics. In some of those situations, you had to have access, for instance, to internet in order to be able to find out where those were. But in particular areas of the city, there was these vaccine deserts. So even if you were, for instance, in a hotspot identified community and were eligible to get your vaccine, if you were also simultaneously living in a vaccine desert, it then makes it very difficult to actually go and receive the vaccine that you are now eligible to receive. The third one that I wanted to mention is a general and insufficient engagement with medical distress. So here we are talking about, for instance, the history of colonialism and experimentation and the ways in which these were not adequately dealt with among particular communities, for instance, among Indigenous communities, and the on-the-ground working with particular communities that needed to have been done in order to engage, for instance, with medical distress in the context of colonialism and this history of experimentation on Indigenous folks that might make them more reluctant, for instance, to get a vaccine. Okay, so all of this being said, and having identified a number of particular problems that existed within those 4 parts of the Ontario government's response, the second question then is, what is the Ontario government's obligation to deal with the particular issues that have been raised? So we approached this from looking at whether there was a moral duty for the Ontario government and its public health units, and then we looked at whether there was a legal duty. So in terms of the question of whether there was a moral duty, ultimately we answered that yes, there is a moral duty. We looked at a number of scholars who have worked, for instance, on theories of health ethics as they relate to morality. And I've put 2 examples, for instance, up on my slide here. And in order to answer this question of whether these deprivations in health ultimately lead to an obligation in order to deal with those particular disparities. So for instance, if we look at J.P. Roger's argument is essentially that disparities in health lead to deprivation in health. And in addition to that, they lead to a deprivation in other capabilities. And because they not only lead to this deprivation in health, but they also lead to this deprivation in other capabilities, and because of the view that policy should bring people as close to their functioning as naturally circumstances permit, the argument then is that this is morally wrong. So if we are to then kind of bring that into the context of what we were talking about here with the Ontario government, the argument then is that the action or inaction by the Ontario government that leads to subminimal care, that leads to deprivations in health, but also leads to deprivations in other capabilities, is morally troubling, and as such, there is a duty to address them. Cynthia M. Jones also approaches this question of moral duties in the context of health inequities. And you'll notice, for instance, that Roger, Jones, and a number of others who work in this area fluctuate a little bit between their use of inequities and disparities, but ultimately in many ways seem to be referring to them in a synonymous way. But if we look at Cynthia M. Jones, rather than Roger, who looks at this fact that disparities lead to something that is morally troubling, said that health disparities in themselves are a moral wrong. They are a moral wrong because they perpetuate substantive inequities and they exemplify historical injustices from racism, colonialism, discrimination, and oppression. And Jones goes on to kind of articulate in a way that Roger doesn't quite, what then and why then there is a moral duty to deal with this wrong. And what Jones ultimately says is that moral principles entail duties to act or not act on whether an action is found to be wrong. As such, if health inequities are a moral wrong, then there is this subsequent duty to act. So if we translate that again to the current circumstances, inequities that are exposed by COVID-19 are a moral wrong. As such, because there is this accompanying duty to act, the duty to act would be that there is a moral duty owed by the Ontario government to address these. When we move into talking about the possible legal duty, this is where things become a little bit more complicated. And we looked at this on a couple of different levels. So we looked at whether there is a legal duty that stems, for instance, from international human rights obligations. And we looked at whether there's a legal duty that stems, for instance, from particular sections of the Charter. So in our first section, we looked at whether there's this legal duty under international human rights obligations. And here, we focused on the International Covenant on Economic, Social, and Cultural Rights, which recognizes the right of everyone in Canada to the highest attainable standard of physical and mental health. State parties have to prevent, treat, and control an epidemic and ensure medical attention without discrimination of any kind. Because this is a legally binding instrument, and state parties are responsible for fulfilling their obligations through legislation and domestic measures to the extent of their available resources. This has also been found to be binding on federal government and provinces and territories. And every year, or every 5 years, I should say, a report has to be given to the UN Committee to Economic, Social, and Cultural Rights, who examines this report and ultimately makes recommendations. But at the end of the day, there are always questions when it comes to international human rights obligations and these international covenants about the extent to which they are going to be particularly enforced in this provincial kind of point of view. The second is also the International Covenant on Civil and Political Rights, which establishes everyday rights, such as, for instance, prohibiting discrimination. We then focused in on the question of the Charter of Rights and Freedoms and whether a legal obligation could be owed, for instance, under sections of the Charter. So we focused in on Section 7, and we also focused in on Section 15. And there actually have been a variety of class action lawsuits in the paper. I referenced one of them called the Nisbet lawsuit. The most recent information that I've been able to find on the Nisbet action is that it and another action called the Robertson action had both been brought in front of the Ontario Superior Court in order to discuss this question of whether the class actions would be certified. Ultimately, both of those class actions argued quite similar things, but they sought liability in a different way, and carriage ended up being granted to the Robertson action. At the time of writing this paper, all that was available was the initial kind of notices, and that's what we relied on here, but there has been a slight update ever since that. So like these papers that looked, or like these class actions, I should say, that looked particularly at the case of long-term care homes and framed some of their arguments in context of the Charter, we also looked at whether the same could be done with regards to the things that we had found. So for instance, under Section 7, the question is whether decisions or actions taken by the Ontario government and its public health units compromised health and security, and increased the risk of death. And the question is, of course, whether those rights were deprived in a way that does not accord with principles of fundamental justice. So for instance, the failure to collect data with equity-related indicators. Did this result in compromising health and security and increasing the risk of health? Testing priority and the vaccine rollout plan. Did those, for instance, compromise health and security and lead to an increased risk of death in particular populations? These are the kinds of questions that we would be asking, is whether there's that impact on security. The second section that we looked at was Section 15. And here, the question that we were asking was whether the conduct by the Ontario government and public health units amounted to differential adverse treatment that perpetuated disadvantage on grounds of discrimination, such as race, national, ethnic origin, and citizenship. Here you'll notice that we framed our arguments on the basis, for instance, of race and citizenship, given that income isn't a ground of discrimination under section 15. And we looked at, for instance, whether things like COVID-19 testing not being available in congregate settings, whether that high proportion of racialized individuals who were impacted by this, whether that is an infringement of section 15. We looked at, for instance, whether the vaccine rollout plan and the fact that, for instance, Black and South Asian folks who are not included in phase 1 and only indirectly included in phase 2, despite being the hardest hit, whether that infringes their section 15 charter rights. Again, also important to remember that in the context of looking at this, we were looking at this under the section 15 Fraser test. We have since had the Sharma test, which does to some degree change our understanding of the meaning of substantive equality potentially. Unfortunately, we do also identify that there would be a lot of barriers to these section 7 and 15 claims. So for instance, the fact that section 7 and 15 claims do not include positive rights. So for instance, Eldridge, which had to do with the deaf community, is a case in which it is made very clear that positive rights are not included, but also indicates that if something is provided, such as a healthcare service, it needs to be provided in a way that is equal to all of those who are seeking it. Charter rights are also not absolute because of section 1 of the charter. Under section 7, there are particularly onerous requirements, for instance, to show sufficient causal connection. Under section 15, many of the claims that we are suggesting here would be claims of adverse effects discrimination, which are much harder to demonstrate. There is also section 15.2, which allows the government to implement programs that are aimed at helping a disadvantage. So the very last thing that I wanted to say is, irrespective of whether a legal duty would ultimately be found in court, and I'll be very interested to see what happens in the context of the class actions that are currently going forward with regards to the long-term care homes. There is this moral obligation, and evaluating the 4 aspects of that response indicate a number of measures that could have been taken and or could be taken in future pandemics in order to take into account structural racism and low-income health inequities, and in order to improve those pandemic findings. So there are a whole number of them, one of them being in general better pandemic preparedness. Despite the pandemic having been predicted for a long time, there were not thoughtful measures in place that were adequate to deal with what ultimately ensued. But there's other things, right? We talked about the collection of data with equity-related indicators. That could have been done from the very beginning and could have allowed that response to be tailored throughout. Small things on the ground, like less stringent ID and documentation records. These kinds of things deterred people from seeking care because they didn't want to, for instance, indicate what their status was in Canada. Improve priority setting for vaccines, rethinking a priority phase approach and how we might be able to build on what was done in order to better encapsulate those who are most impacted by the pandemic. Strategic planning for urban Indigenous peoples, for instance. There was a lot of planning put in place for Indigenous folks who are living on reserve or in more remote areas, but not a lot that was done, for instance, in urban areas. So these are the kinds of things that we can think about going forwards. And so I will just end there.
Thank you very much. I'll open it up for questions. Maybe I'll start with Sarah.
Thank you for the presentation. I had some questions like that were referring to your article specifically. And so you were talking about like Canada's like past pandemics and structural racism in those. Then you later on were talking about how health professionals like educate themselves on Black history, and I thought it was interesting when themselves. I was wondering if like med schools and nursing schools and those types of professional schools teach anything like that, and if they don't, like what kind of resources would you expect medical professionals to have access for that?
Yeah, that's a great question. So when I use the wording educate themselves, I didn't necessarily mean that they had to go out and find those resources. I think what I was trying to get at is that institutionally, we need to put better programs in place in med schools, for instance, to provide them with that information. But also hospitals, public health units, as part of their ongoing professional development, those could be the kinds of things that are broached in those settings. And I think the main thing that I was trying to get at there was talking about, so for instance, in the context of the pandemic, there was a lot of discussion about the wording of vaccine hesitancy, which creates a bit of a stigma because it suggests that some people are hesitant to get a vaccine. And there can be a whole variety of reasons, right, why someone may be hesitant to get a vaccine. Often though, when people use the word vaccine hesitancy, as certainly in the context, for instance, of Indigenous folks or Black folks who have these long-term experiences of discrimination with the Canadian healthcare system, what we're actually referring to and how we should better phrase that is the medical distress that exists within those systems because of this history that could lead people to have vaccine hesitancy. So even something as small as understanding the roots of something like vaccine hesitancy and where those may come from and why they may be connected to intergenerational trauma, experience trauma, anti-Black racism, experiences within these institutions, those kinds of things I think need to appear in terms of like a professional development program, also in anticipation of the fact that we likely will have more pandemics, but also in anticipation of the fact that we should be using this as a glimpse into the problems that exist in our healthcare system and how we can improve those.
There were two related questions, one by Chris and one by Claire. Maybe covered, I mean, Chris is covered,
Yeah.
Claire covered as well, or?
Largely covered as well.
Okay, so I'll go to Vivian.
Hi, in the paper you talked, like one of the things I thought you really did well was discuss past pandemics and kind of like what we could take away from them in terms of like the impact, the inequitable impacts. And I was just wondering if like during your research, you found things that were like tried that maybe failed to kind of help with those inequities, and like if we use that data, because I feel like we talk a lot about the things that are still actively at play, which obviously is what we should be focusing on, but like maybe things that we tried in the past that didn't work that maybe could help like frame what we do now.
Yeah, that's a great question. So one thing, myself and Professor Lara Corey at McGill are in the middle of trying to construct this article where we're looking at liability. And one of the things that we ultimately are finding again and again is that lack of pandemic preparedness is something that led to a lot of the issues that exist. And something that we anticipate would be an argument is we weren't prepared, so we weren't able to do this, thus you cannot hold me liable for this, this, and this. And so we're trying to construct an argument that actually there was an awareness about certain things. Those steps were not put into place, and so there is an accountability problem that exists there. Because there were plans, for instance, that were put in place post-SARS as an example. But coming to your question, one thing that I did notice in the context of kind of looking at those old documents and thinking about what happened during COVID-19, particularly in Toronto, is that some of those older documents talked particularly about how we needed to engage more with particular community groups, whether those be like faith-based groups or like a variety of different groups that exist in the community. There was ones in Peel, there was a collective, for instance, in Toronto that worked particularly with communities of Asian descent in order to talk about the vaccine. And so working with communities is something that did, I think, improve during this particular pandemic. But whether I feel like the government actually supported that adequately is another question. What we saw were examples of community organizations taking the lead, taking initiative, and dealing with questions of like medical distress, for instance, or helping people find out where they could get their vaccine, or linking people with others who could drive them to get their vaccine, et cetera, et cetera. And so we saw that panning out better, but I don't know actually if there was better support for that. And I think that is something that we can learn from, particularly going forward. It's a really good question.
Follow up, yes?
Yeah, so I'm really interested in hearing about how those factors maybe could be implemented more by the government instead of community run, as well as you also mentioned certain individuals instead of there was a lot of talk about misinformation, and especially put on individuals who were misinformed who then continued to spread misinformation.
Yeah.
So I would love your thoughts on maybe potentials for the government to improve in their own side instead of just community oriented activities and implementations. Do you have any further thoughts on that?
So how they would better support these communities, for instance?
Or access and inform these communities, because a lot of them are racialized communities or communities of low income. And yeah, like you mentioned, a lot of them, the initiatives were community run or community led. So I would love to hear your thoughts on maybe how the government can do a better job to, you know.
Yeah. Oh, it's a great question. So I'm actually a sociologist before a lawyer, so I always think that law should be informed by people in their actual lived communities, and that is where all of our policy making should come from. I think one of the things that we saw work really well was the way that particular communities worked alongside their public health units. And I wish that we could have seen government then watching the success of that and implementing protocols based on what they learned from that to suggest to the other public health units that they could take similar steps. And so I see that as a potential avenue. We always think from like this top-down approach. So we always think about government policy putting in place and affecting the public health units, who then essentially put in place what they've been told and adapt it slightly to the community, without, I think, thinking enough about the other way and the way that government should be looking at these public health units, learning what's working in those communities, and asking that question if that may work in other public health units and among other communities as well.
Okay, Caroline.
So you already touched on this a bit, but I was wondering if you could speak more on how we can actually prompt the government to implement the proposals contained in your chapter.
Yeah.
So you mentioned that better pandemic preparedness could have been the first important step taken by the Canadian government to help prevent inequities. And we're now at a time when I think that we are able to improve on the provincial as well as federal government's pandemic preparedness, because, you know, the pandemic's not over, but we definitely have more room to breathe and look into it. So there's a lot of great ideas that you have mentioned, and I was just wondering, I think there's two parts to my question really, on how the litigation with the constitutional challenges would pan out in your opinion. I know you mentioned that there's barriers, and I'm wondering if the constitutional challenge would be more favorable or less favorable to those seeking it, and then also if there's other avenues, other litigation avenues and other avenues in general to motivate the government to implement these changes.
Yeah, it's a great question. I read your Professor Levin's center on the questions, and your question really stumped me. It's a really good one, and it's a hard one that I wish I had a very convincing answer to. But here are a couple things that I thought when I read it. The first thing is that, so for instance, let's take the Nisbet class action suit. They are pursuing both liability and tort, and they're also pursuing these charter claims. And I'm sure we will see other kind of human rights claims that are brought under either the charter or brought under provincial human rights statutes. If you bring it under the charter or under a provincial human rights statute, you're not going to get a huge amount of money. So really what you're looking to do is you're looking to send a message, right? You're looking to send a message that what was done was not right and that it needs to change it. I think though, because of section 1, because of section 15.2, because of the fact that many of this was adverse effects, I think there are going to be a lot of barriers to successfully being able to argue infringements under the charter. And I think in a lot of cases, section 1 will be used in order to kind of save what happened on the context that we were under these kind of exceptional circumstances, and that the measures were proportionate to these objectives where they were trying to deal with death and illness and suffering in the best possible way that they could. If you think about it under torts and you think about the liability potential there, I think that that actually has a higher chance of being successful from what I'm seeing so far. That is bringing up a whole host of its own issues, like who exactly was negligent? Who exactly is accountable for this mistake? Is it an individual physician? Is it the hospital? Is it the government? That in itself is proving to be a pretty kind of difficult to understand thing. And of course, in these circumstances, governments have particular protections that are in place as well. So potentially neither, maybe the latter. But given all of that, if nothing else, these kinds of suits being brought are raising attention. They will bring some kind of media and awareness and discussion around them to point out the things that went wrong. I think in long-term care homes especially, given all of the media that has centered around all of the mistakes that were made, I would hope and I think that we have learned a lot, and hopefully that will be implemented into changes going forward. In terms of things like structural racism and income, those are the kinds of things that have received, as often is frustratingly the case, a lot less conversation. And so my worry is that those will receive less focus going forward. And which is crazy because Dr. Tam at the beginning of the pandemic said, we anticipate that marginalized communities will be disproportionately impacted because we know that health crises like a pandemic basically put a microscope on all of the issues that exist within our healthcare systems. And despite all of that, we didn't see an adequate amount done. It's a really good question.
Yeah, follow-up question about measures. You focus particularly on things that have not been done, so or that were inadequately provided, lack of vaccines, lack of possibilities for isolation at home. One of the things that happened in long-term care homes is that the measures to prohibit or to limit visitors led to an exclusion of family caregivers.
Yeah.
And again, I think there's a structural component there because it's often underfunded commercial homes where family caregivers were basically providing essential care. And suddenly that fell out. And people, there are reports that people starved and died because of lack of nutrition and water. So I'm wondering if, I mean, can you see the structural component there adding on to legal action on in that particular context, or that be more kind of just an argument and on top of existing transaction lawsuits? And I'm just wondering.
Yeah, no, it's a good question. How does that kind of factor into the way that we think about constructing these particular arguments? Does that help advance those arguments by saying that this additional problem occurred that we should be taking into consideration? Or is it something that can be used to deflect liability on the basis that we had to make this choice because it could have led to this, or not? Yeah, I'm not really sure.
I've been thinking about, I mean, there's a student who did a review of reports of, for example, also one of the things that she looked at was how abuses in long-term care homes increased. So reports of abuse. Anyway, so Bryn.
I think you answered the first question I had about sort of where you see the barrier coming in, probably at both the section 7 and 15 and in section 1. And I don't know if you have a sense of this yet, but are you aware of any uptake of your paper and of your recommendations by the government yet? Or have you been in like an asked to consult, or have you seen any positive outcomes yet?
Yeah, that's a great question. I think every academic hopes that when they write these things, that somebody out there will actually listen to what they have to say and put it into place. I have no evidence that any of these suggestions have been put into uptake. But that being said, I have also, in addition to publishing, we published a multitude of different papers related to this under our COVID-19 grant. But given that peer-reviewed papers are not always the most accessible format, we also publish them, for instance, in like the Barreau de Quebec. They have like a policy suggestion commentary, and so in one of their books we published like the key takeaways and findings and suggestions for policymakers in Quebec of what we had found. And we'll definitely consider to look at those other avenues where you can kind of find these recommendations in a much more straightforward, like point form list that are much more easily findable by policymakers and a lay audience.
So, Megan Peters, maybe your question has been answered.
Yeah, I think it was mostly answered. That was interesting about the update on the class actions. My question had been,
Okay.
Yeah. I think that was
Okay, Megan Corbett. Mhm.
Hey, I was just wondering if you saw examples in other provinces of approaches I took that were better, in your opinion, kind of on the issues that you've identified. I know one thing you exampled in the article is that, for example, I think Manitoba distributed free masks kind of universally. I
Yeah.
was wondering if there was other examples that you saw that Ontario could implement in the future, and whether there are systems in place to kind of allow that knowledge to cross provincial borders.
Yeah, great question. So one in related to housing, for instance, and housing isolation was in the Northwest Territories. They did a much better job of the way that they made housing available for folks who needed to isolate because of a positive COVID-19 test. And one thing that they did that I think would be such a simple thing to have changed in the Ontario context was just that at the time that you went in and did your test, they told you about the housing that was available to isolate, and you could actually go directly there in anticipation that when you got your test back, it was potentially positive. One thing that seemed to go wrong in Ontario is that there was housing that was available. People would go in, they would do their test. There was this huge backlog, so they would wait whatever it was, 2 days. In the meantime, they would be, for instance, in their house in contact with multiple people who then, for instance, would get COVID from them. And then they would find out, and at that point, well, everybody in their house was already sick, so it didn't really make sense to go into this housing to isolate at that point. So that was an example, and such a small procedural way in like what information is given at the time that you get a COVID-19 test that could have, I think, made a change.
Okay, Jacqueline.
Hi, this is similar to some of the other questions that have been asked, but I know you focused your research on the response of the Ontario government and public health units in particular. I was wondering if the work of Ontario health teams during the pandemic had come up as another response to potentially evaluate, because OHTs are integrated partnerships between community health centers and primary care, social care services. I think they'd be uniquely positioned to address those underlying social determinants of health. And so I saw like a few examples of OHTs operating like mobile vaccine clinics and pop-ups. Was just wondering if that was something that came up in your research, particularly the work of OHTs. I know they're relatively new. And if so, also why you decided maybe not to focus on bringing that aspect into the paper.
Yeah, that's a great question. So there were a couple of spots in the paper where we mentioned, for instance, like you said, like the pop-up clinics. And then if you look in the footnote, it's an OHT that brought that pop-up clinic that was useful, for instance, in the context of these vaccine deserts that we're talking about. And you're absolutely right. They are a great focus for learning about best practices and kind of these community-oriented initiatives. We used them in a couple of places, and then these kind of examples of some other community organizations just smattered throughout the paper to give examples of the kinds of things that could be done. The paper actually was cut down significantly, if you can even believe it, from its earlier draft. So we had to take many of those out and decided to ultimately kind of give them as examples. But you're absolutely right. I think an entire paper could be written alone on OHTs and the lessons that could be learned by the initiatives that they took during the pandemic. It's a really good point.
Okay, any other question? Audience? Maybe comment half a question with respect to your suggestion that there has to be much more bottom-up development policy. And so I remember opposition sharing with me a story about she particularly covers marginalized communities, and so certain measures that seem obvious to most people. For example, the fact that there were calls to homes where people were asked if they saw anybody else, so contact tracing, but particularly also controlling whether the person had been going out and had been seeing other people. So, you know, that doesn't seem to be a big deal for most people. You get a phone call, you have to answer, say, 10 questions, and anybody here who was infected before, certainly before the vaccines came out, may have been confronted with it. I remember getting a phone call. You become a little bit annoyed because they can call you whenever, and you have to be on the phone. They check whether you're home, I mean, she gave us an example how she had a patient who was a single mother and with 5 children or something like that. And so she said, well, this is a young mother.
Yeah.
She has COVID, so she's not in good shape.
Yeah.
Kids are sick, and one after the other, the small household is getting infected. And she would be on the phone for hours per day because she would have to respond, and they would have this scenario probably in front of them, the callers, and they would call and then hang up, and then somebody else would call about child 1, child 2, child 3.
Oh.
So everybody who had been infected had to answer, or I mean, it was all through her, all of the questions that the bureaucracy prepared. I know it's kind of a small thing, but it actually
No, it's huge.
created a huge stress for this young woman, you know.
Yeah.
So I mean, you have 5 kids in the household running around and being sick. Anyway, I thought this was interesting. So we kind of we forget that measures that may seem not too burdensome can become incredibly burdensome depending on the circumstance.
Hugely so. Even,
We don't, when these measures are developed, people don't think about it.
yeah, yeah.
Yes, anyway. Any other question? Okay, so on that note, thank you for your presentation and for
Thank
answering all of
you.
our questions. And if there's any further question, I'm sure they can email.
Absolutely, yeah. Thank you for all your questions. They were great.